Hi, everybody. It's Professor Mulcahy. This week's content will be inclusive of communication and collaboration in professional nursing, and we will also be exploring what happens when communication and collaboration break down and we have workplace violence or incivility. And that is a Padlet. It will not be included in this lecture video. I have curated some sources for you for that so that you can do the discussion board posting. All right, so for communication and collaboration, we have 6 learning outcomes. You will identify and describe the phases of the traditional nurse patient relationship and how important communication is to that. We will explore the concept of professional boundaries, very, very important. We'll discuss factors that can help or hinder communication in nursing. We'll examine the role of bias in healthcare and how that can lead to miscommunication and poor outcomes. We'll identify strategies in providing care to patients with limited English proficiency. Some of them may speak English, but they may need interpreter services for highly technical medical information. And then we will identify key aspects of collaboration and interprofessional communication. So the 3 phases of therapeutic nurse-patient relationship are orientation, working, and termination phases. The orientation is the shortest one, but it is very important to set it up right. So sometimes the orientation phase happens when you admit the client to the care setting, and sometimes it happens at the beginning of your shift. And it's important to establish trust, to set some goals, and establish what's important to your patient so that you can bring their preferences into your plan of care, and establish a rapport and set those professional boundaries. So it's important, but it doesn't take long. So let's say that it's a shift change and you go in for bedside report. Already you're communicating when you knock on the door, smile and introduce yourself, that you are the nurse for that day. My name is Kathy. I'm a nurse. And that's, important because sometimes everybody on a unit's wearing the same color scrubs and they don't know who the nurse is as opposed to the housekeeper or the deck or the secretary. And it could be anybody. So it's important to establish that you are the nurse. Bedside reporting is the safest way to do it, and it communicates to that patient right away. They can trust you. You care because you are tracing their IV lines. You are looking at their Foley. You're talking to them directly. And they're able to verify that that communication is appropriate. So you're establishing trust in that moment. When you go over to the whiteboard and you write your name and your little ASCOM phone or whatever kind of device you have, whatever way it is that they can contact you, and you write about their plan of care and what's important to their stay, you're also establishing that rapport and that trust. And you can set goals. What would you like to do today? You need to get out of bed today. You had surgery last night. It's important for you to walk. So you're setting the goals. Now, the working phase is most of the time you're spending giving care with that patient. And then there's the termination phase. And the termination phase defines that relationship and keeps the boundary clean. So at the end of your shift, you should go back into the room and give bedside report again and say, okay, I'm going home now. Is there anything that you would like me to tell Carrie, who's taken over for me? And the new nurse starts their orientation. If it's a discharge situation, you make clear that this is what's going to happen. You're going to transition back to home and follow up with your primary provider, or you're going to go to like an outpatient rehab center or something like that. But you are establishing that this relationship is ending, but I have taken steps to make sure that there is still continuity of care. All right, professional boundaries, extremely, extremely important. Social media has changed the landscape on professional boundaries. And so the NCSBN, which is the National Council of State Boards of Nursing, put out a position statement, Nurse's Guide to Professional Boundaries in 2014. And what they identified, and it's kind of interesting, is that there is a power imbalance between the nurse and the client. Because the nurse has input into decisions that will impact the client, and the client doesn't always know what input's going on. So, even things like, I'm going to get your medication, or I'm going to decide which pain medication to give you based on your answer to my pain scale question. Those things give us power just by virtue of our position. We are in a position to do things that can help or harm them. So there's some imbalance there. And also, we have access to some of the most private information that nobody else knows. And they don't know as much about us, hopefully, because hopefully we're not disclosing all our personal information to them. The boundary violations that occur, and I've seen many of them, happen when there is confusion between the needs of the nurse and the needs of the client. So if the nurse is super busy and she maintains distance, she doesn't make it into the room, or she rushes through care, or she doesn't listen to the client, that's a boundary issue of too little care. Or if she's like, you know, telling all her, oh my gosh, you wouldn't believe how busy I am today. And she makes it about, or he makes it about his needs, or she makes it about her needs. If it's about the nurse's needs in that interaction, there's been a boundary violation. Okay. If you're sharing things that are not related to that patient's problems and that patient's needs, doesn't matter. I mean, it's one thing if you're talking to a new mom and you say, oh, my baby was fussy too, or, I remember what it was like to breastfeed. That's relating to the client. If it's about you and your opinions or your values or your beliefs, if that communication is in some way more about you than it is about them, you've crossed a line. Okay, and so here it is again. This is the continuum of professional behavior. There is a helpfulness zone, or the zone of helpfulness. That's where this triangle is. That's a therapeutic relationship. It is centered on the patient's needs. Too little attention to that client's needs is one violation of that boundary. And that can happen in settings where there's burnout, high volume, understaffing, where you just can't give the care that patient deserves. And it can happen in nurses that just don't know what that client needs because they haven't been taught or kind of made to put that client first. And sometimes it's the culture of the unit. People are kind of tough and hard and like, yeah, he's a drug seeker, something like that. That can be on the too little end of the continuum. Too much is when the care provider blurs the lines between personal stuff and professional stuff. And I have seen that happen, especially now with social media. You have a patient that you've taken care of for a long time. Maybe they've been in the hospital for a month or a month and a half, or maybe you're in home care or you're in hospice. And you've spent so much time with them that you've developed a relationship that sort of transcends the professional boundary line. And you need to be mindful of that. Do not friend your patients on social media. That's inappropriate. Don't make plans for after discharge to see them again. It's also inappropriate. And be careful that you're not getting more out of that relationship in a personal sense than they are. Okay, so we're going to talk about bias. Bias is another way that we can impede communication and cause poor outcomes. A bias is a prejudice, a preference, a stereotype, an attitude that says a category of things is something I like or don't like. Okay, it's a prejudice. We all have bias somewhere. It's wired into us. It helps us make decisions in the absence of information. They can be favorable. Go Phillies. I love the Phillies. They're the best team, even if they lose every game. They're the best team. That's a bias. I'm biased towards Phillies. Can't help it. Or it can be unfavorable. I hate the Red Sox. Okay? Doesn't matter how well they play. I hate them. That's it. I don't actually hate them. Do love the Phillies, but it can be explicit, right? Where I say it out loud. I'll say it again. I love the Phillies. I'm voluntarily making a choice to express that statement. And I know it indicates that I am biased. Explicit bias you are aware of. You verbalize it. You endorse it. You choose it. Implicit bias is sneakier and potentially more dangerous. Implicit bias has to do with attitudes that we've either absorbed culturally through media or in our upbringing or our personal experiences with people. Implicit bias can also be favorable or unfavorable. The problem is that when we are in a professional situation and we are making those decisions that impact people's lives and their health and their care experience, is that they can frequently have negative impact. You develop a bias and you act on it when you don't have the information. So if you already think you know everything there is to know about people who come from Switzerland, and you meet somebody from there and you've made assumptions, that can influence your care of the patient. And I'll give you a real life example because I don't really actually know anything about Switzerland, hardly. But there are some providers that harbor implicit bias and feel that African American patients exaggerate their pain and don't feel it as acutely as patients of other races or ethnicities. If you're acting on that bias and the patient says, my pain is 8 out of 10, and you give them 650 milligrams of Tylenol instead of the 2 milligrams of Dilaudid or whatever's ordered, you've now under medicated a patient based on a bias. Okay. That's really harmful. And it happens all over healthcare. We need to be more aware of things like that. And the way to overcome bias is to listen. If you're listening to your patient as if it's the first time you've ever heard that information, and you're really, really waiting for that response, that can help you learn the things you don't know so that you don't have to act on a bias. So you're always going to have to examine your bias, and you always have to listen to your patients. And that is going to be the end for this video.